welcome back from lunch. It was a beautiful day here in San Diego. And what I would like to say is that I'm Michelle Peterson with CCCMHA, soon to be CCBHA. And we represent the providers, and we're very excited to be here today with a panel. And you know, it's been interesting to see so many folks who have known each other a very long period of time in the business and kind of reflect back on the generations of work that they've done on behalf of the community. And one of the things I was really thinking about is early in my career, I had this conversation while working at the UN with my advisor there, and she had said that, you know, policy happens at a very high level, and it's the people at the community that really retrofit those policies to fit the community and families and people at the local level. And so I'm very excited to introduce the provider panel, because I think when we reflect on this morning's initiatives from Karen Baylor and her staff, they are doing an extreme amount of heavy policy lifting at the state level to improve our system of care. And we collaborate and contribute to that. But this panel is also recognizing where we're having successes and challenges in implementation of those changes. And so we're gonna highlight those today, this afternoon. So with that, I'd like to introduce Kimberly Bond. She is the CEO and president of Mental Health Systems, a large nonprofit provider organization in San Diego County and also in Nevada. Her role as CEO and president gives her the opportunity to provide services to 80 programs throughout the state of California and also in 3 divisions. She's a leader in mental health and recovery communities. Ms. Bond has served as the president of numerous professional associations, including statewide and nationally. She's been a member of CADP and WASLI, which is the Women's Addiction Services Leadership Institute, and the California Association of Alcohol and Drug Program Executives. Kim was nominated in 2015 for the Most Admired CEO in the nonprofit sector by the San Diego Business Journal. She's recognized as a finalist in Healthcare Champion Awards in San Diego Business Journal in 2014. She's honored as one of the 20 most powerful women who are tabulating paths and making a difference in our community, says the San Diego Business Journal. She has a marriage and family therapist license, and we're very excited to bring Kim on as one of our board of directors also. Vitka Eisen is with HealthRIGht 360. She's the CEO. Dr. Eisen started in health and human services field in 1982 and has a lifelong commitment to supporting people and communities struggling with addiction and incarceration. In her tenure, employment history with HealthRIGht 360, she served in several capacities before being named the CEO in January of 2012. She's instrumental in the Haight-Ashbury Free Clinics, Walden House merger, and the subsequent HealthRIGht 360 rebranding. Really a demonstration of integration. Dr. Eisen was named CEO and the merged entity on July 1 of 2011. Dr. Eisen is a Walden House graduate, class of 1987, and received her MSW from San Francisco State University. We also have Al Sinella, which I feel strange introducing him in this room because I think everybody knows Al. But I'm going to go ahead and let you know what his background is. In 1972, Al Sinella has guided a progressive range of integrated behavioral health care services at Tarzana Treatment Centers. He's the president and chief operating officer. Executive officer, excuse me. In this capacity, he has developed a range of substance use disorder and integrated health and mental health primary care services, responsive to the needs of uninsured people and low-income Los Angeles residents as persons with private as well as persons with private resources. The response to this growing HIV epidemic, these services were interwoven with comprehensive HIV prevention, intervention treatment services, creating a nationally recognized model of HIV services for drug users. Under Sinella's leadership, TCC, the Tarzana services, have expanded to include 5 family primary care clinics, case management and treatment programs tailored specifically for persons for prison parolees. Mr. Sinella has a primary oversight of agency budget and government contracts. He's also the California Association of Alcohol and Drug Program Executives for CADP. and is active member of state and local advisory bodies. So thank you. And our last panelist today is Patricia Judd, PhD. She received her doctorate in clinical psychology from the California School of Professional Psychology in San Diego and a master's of social work from San Diego State University. Dr. Judd is a clinical professor in psychiatry at the University of San Diego School of Medicine. She's the director of the outpatient psychiatric services at Hillcrest, and she has served as the director of San Diego Co-Occurring Substance Use Disorder, Use of Other Mental Health Disorders, COD. I think I slaughtered that, I'm sorry. Anyway, with that, I'm going to give this up and just really thank you all so much for joining us today, and we look forward to hearing about your successes and challenges with integration.
Thank you. I'm Kim Bond. I'm the president and CEO of Mental Health Systems. We're a fairly large nonprofit based in San Diego, but we have services all over Central and Southern California, so we're in multiple counties, and we provide both mental health and substance abuse treatment, and we have since our inception back in 1978. So we've been talking and struggling with the integration of mental health and substance abuse treatment for many, many years. As we've moved forward, and we've done a good job with our programs, and primarily in San Diego County and in other counties, really making sure we have staff from both disciplines. On our treatment teams, we do co-ed supervision, so no matter what discipline you're in, if you're in a particular area, you all go to the same clinical supervision. So we've had a lot of crosstalk. And I think as an agency and the different counties and programs that we run, we've done a fairly good job moving down the spectrum, but there are still some challenges. And that's really what we've been asked to talk about today, what we see as some of the challenges as we're moving forward. Okay, so challenges. The ODF waiver is strictly a county opt-in system. So what we find then is that allows every county to do it just a little bit differently. And when you're across multiple counties, or if you're a client that's moving from county to county, you can get different services or you have different requirements. So it's a little bit trickier because of that. Because of the carve-out, and I know I'm in the minority here, but I'm not always sure the carve-out is the best thing for our clients. The mental health carve-out and waiver, it really leaves a bifurcated system for many of our clients. So we have their bouncing back and forth from one system to another. And it really does impact client sharing, or information sharing for our clients. And then pushing mental health treatment, physical health treatment for the seriously mentally ill population into a primary care setting isn't always the best place for a seriously mentally ill person to get their care. If we can look more at getting primary care into our mental health clinics or behavioral health clinics, it's a much better system for the people that we particularly serve. So some of the, these are some of the challenges, just overall challenges, bigger challenges that we face. And then some of the strategies maybe that we could address with some of these. It would be nice to propose and to fund a uniform system of care. I know that's a pipe dream. I know it's not going to happen. I hear several of you giggling at that whole concept, but it would really be nice for the people that we serve if we had a more integrated service delivery system. If we could require that all managed care plans contract with the full county network for serving the full spectrum, so that we don't have to have a bifurcated system, so clients get some of their services in this system and some of their service in the other, but we could have one complete system. Again, it makes information exchange easier, and it also would help the service delivery from our clients. And as you can tell, I look at things from how easy are services to access from our client standpoint, not from the ease of the providers or our government agencies. Going back to talking about putting physical health inside a seriously mentally ill client or behavioral health clinic, probably needs to be a different rate. If you work with FQHCs and you know they need to see so many clients in an hour in order to make their margins or cover their costs, you're not going to be able to see that many seriously mentally ill folks or people with severe behavioral health challenges as quickly as you can other folks in a medical clinic. So there needs to be some compensation or some recognition of the fact that there's going to be lower numbers going through there and being reimbursed at a different rate so that the SMI population or people with serious behavioral health challenges really can get the care they need, and it's not going to bankrupt any of the providers. So if we can look at some of those strategies to combat some of the difficulties on a more policy level, in our opinion, at mental health systems, it would help some of the systems issues go quite a long way. I only have 10 minutes. How am I doing on time? We're good? Let me introduce you then to my next colleague, Dr. Vitka Eisen. Good luck.
Hi, everybody. My name is Vitka Eisen. I'm the CEO for HealthRIGht 360. I'm also a person in long-term recovery, and what that means for me is that I have not used drugs in 30 years. With the exception of today. And I'm on, so like I have a cold. I took a cold pill, which is kind of like the poor man's speedball. So if I'm talking either too fast or too slow, it's the cold medication. And I got my recovery through a publicly funded healthcare system. So, I mean, I went through treatment programs that were funded through the safety net. So I'm a big, firm believer and owe my life to the safety net, which is why I've dedicated my life to it. So I work for HealthRIGht 360. We're a behavioral health and primary care organization. We offer substance use disorder treatment, mental health services, integrated residential treatment, outpatient behavioral health. We have medication-assisted therapies to support treating substance use disorder. We have 4 primary care clinics. We're in 7 counties in California, 3 state prisons, 2 county jails, and a partridge in a pear tree. We house about, we have some transitional housing as well, and we house about 1,000 people every night in either a treatment bed or in a transitional housing bed, stepping people down from intensive treatment. So that's a little bit about what we do. I often, let me see this thing. So I often get asked to speak about integration from an FQHC perspective, because we do have 4 federally qualified health center sites in San Francisco. But I don't have the standard experience of an FQHC because we are so much of a behavioral health organization that has an FQHC. It's a little bit unique. We have an FQHC that has the ability to refer into, it just has a tremendous amount of supports for behavioral health, which is not often the case for many FQHCs. And we have, our FQHCs have the ability to move move their patients into, if they meet medical necessity, to move them into residential treatment, which is unique. So I think we have I'm talking about it from that perspective, and I'm going to try to kind of keep on my FQHC hat. So FQHCs, federally qualified health centers, in the carve-out. So an FQHC gets paid a unique kind of payment system for seeing patients. They get basically a bundled visit rate. It's called PPS. I think you may have all heard of it. And it's really a bundled rate for providing primary care. And essentially it's kind of an enhanced rate because you have many patients who come to see you who don't have a pay source, but you serve them anyway. So you don't turn anyone away for lack of ability to pay. So an FQHC gets paid this rate through Medi-Cal or Medicare dollars. So an FQHC typically cannot bill the carve-out for specialty care at the FQHC. They can really only bill the same PPS rate to provide that service, whether that service is a medical service or that service is a mental health service. So the only way that they could take advantage of the carve-outs we have, and that's either specialty mental health or Drug Medi-Cal, is if they didn't put it in their original scope of their FQHC in some way. But many FQHCs did have it in their scope, and if you're an FQHC that's has a grant to serve homeless people, it has to be in your scope. So for many FQHCs, although there's this benefit available, the FQHCs often cannot take advantage of it to enhance care. They have to figure out another way to do it. HRSA has made some dollars available for that, but the carve-out is not it. Also, FQHCs cannot bill for more than one service in a day. So this is a big challenge, and if this was a room full of FQHC people, you'd be like, yeah. This is a big challenge because FQHCs are still essentially a fee-for-service model. And so if I have a patient come in for a medical visit, and the medical provider says, and I really would like to refer you to see the psychiatrist and do a med-eval because I'm concerned about you, they can't bill for that second service, even though a patient comes in for their bronchitis, and the doc says, yeah, you have a bronchial infection, and I'm going to give you this medicine, and I'd like you to see our social worker or psychologist or psychiatrist. Can't bill for the second service. And so what it incentivizes asking patients to come back tomorrow. Not that we would do that, but it does incentivize that because the payment cannot happen 2 times in one. You can't do 2 different services. Even though they're distinctly different services, you can't bill for 2 different services in a day. So that's a challenge. The other challenge is one of the reasons why HealthRIGHT 360 really invested in an FQHC and in medical services is so that we can, for our behavioral health patients, that we can really treat all of their healthcare needs. Because they come to us, and often they have many needs, and we see all of those needs as part of our responsibility towards helping them on their path for their recovery. And so people come to us and they're sick. But the way the law is currently written, so we had this merger so that we can have an FQHC, we can have doctors and psychiatrists and all these great services available. But our residential treatment programs, which I said we have like 1,000 people in beds, are specifically non-medical services by law. So I cannot have medical doctors affiliated. Now our patients, I can move them, I can put them in a little bus and I can drive them over to our clinics. But the doc cannot go and meet with patients, for example, to talk about their medication or do patient education at the sites, because that would mean that our locations were medical services, which they're not supposed to be. So we are in this, it's kind of a conundrum, because we have sick people who we have to pretend we're not doing medical services, even though substance use disorder treatment is a healthcare service. I can't figure that out. But so that's the second challenge. And then the third challenge, it's sort of a policy challenge, but it's really the challenge of integrating 2 different systems and ways of doing things between substance use disorder and mental health treatment and primary care. And so that's really the challenge of having those teams understand each other's work and being able to work together. And that's an ongoing challenge, and the policy challenge of it is that, at least on the primary care side, it's often driven by productivity. They have to see lots of patients. But to really do this work well, that they need to have time to coordinate care, to meet together, to build trust, to do cross-training between behavioral health providers and substance use disorder treatment providers. And I'm going to give you an example of that so you know what I'm talking about. So I have our medical team and our residential treatment team. They have a case conferencing meeting every week. And in this case conferencing meeting, it turns out that a patient who's in our pain management program at the clinic has had a positive tox screen, a urine test for drugs. But the medical staff don't want to tell the people in residential treatment because they're afraid that something bad will happen to the client. And the staff in residential treatment are like, what do you think we're going to do to them? Like we're all on the same team. And the docs and the nurse practitioners are like, yeah, but maybe you'll throw them out. I'm like, no, we don't throw people out for being sick. So it's really about training them. It's about training them to understand each other. And on the other side, the substance use disorder treatment providers don't understand why we can't have case conferences every day. Because there's a lot of case conferencing in behavioral health, but nurse practitioners and physicians are seeing lots of patients, and it has to be scheduled way in advance. So you really have to invest. You have to have a mission to do it, and a passion to do it, and a commitment. Management has to have a commitment to make sure that there's time, so that the staff all really understand that we're all working together to improve the health of the patients. So in terms of the carve-out, HealthRIGHT 360 has sites that are not in scope, that we are able to offer a more robust full substance use disorder mental health benefit. We do access the carve-out. We do have Drug Medi-Cal sites. They are not embedded within the heart of our FQHCs, but they're close. And so we are able to provide enhanced specialty mental health and substance use disorder treatment services for our clients. I believe there's legislation that's moved through. I don't know that the governor's going to sign it, but there's legislation that is moved through that would relax some of the rules around billing for mental health services on the same day as primary care. So we just want to see that legislation get passed and approved by the governor. And in terms of the non-medical treatment for residential, the whole is it medical, non-medical? Again, I think there's legislation that was approved by the legislature that is sitting on the governor's desk for approval that says that you can have medical service incident to residential substance use disorder treatment without getting in trouble. So that's good. And then finally, as I said earlier, really to work with complex patients who have primary medical conditions and co-occurring behavioral health conditions, the organization has to be willing to devote the time and energy and effort and commitment to making sure that there's real opportunities for integration, that there's cross-training, that there's support for staff, that people understand what the work is and that they can work together. So, with that, I'll turn you over to the guy nobody knows, Al Sanella.
Thank you, everybody. I'm not a PowerPoint person, so if I butcher this, you'll have to forgive me. I wanted to comment on my comment this morning about my feeling that I'm not sure how other people feel about the urgency of the implementation. And I wanted to make it very clear that wasn't a carom shot just at my friends at the state, but really it was a carom shot to everybody in this room and beyond. I really, struggle with it often. Keeps me up at night sometimes, frankly. I don't think that we move at a fast enough click for the folks that we're serving. They die while waiting on us, frankly. So, and I say that also to the provider community. I, have a lot of contact with the provider community, and I'm often puzzled by how slow they are moving to ready themselves for this massive change. So, in any case, the other disclaimer I wanted to put out is I did not get the memo, or if I did, I missed it, about what was supposed to be put together for today's session. I did have a conference call about it, but somewhere I missed that too. So you'll have to bear with my presentation here, but I'm going to thumb through here. It's 22 pages, and I'll try to make it much shorter. But one of the opening questions is, what does integration of mental health and substance use in primary care look like? And the best way I can answer that question is to give you a picture of Tarzana Treatment Centers, because I think it fits into that. And so Tarzana Treatment Centers was organized in '72. We're not-for-profit, over 600 employees. Primary care, substance use, mental health, HIV services, all part of our mix. Revenue sources are all the usual public sector, but also private sector contracting. Specialty care, again, specific to substance use, mental health, HIV, housing. We're embedded in 3 different ER rooms to do assessment and linkage to care from those ERs. In-home care, part of our HIV continuum. We're accredited by the Joint Commission for Hospital, for behavioral health at all of our locations, including our clinics, for opiate treatment, both inpatient and outpatient. And we also have 2 certifications from the Joint Commission, one for primary medical home and one for behavioral health home. Those are across the organization as well. We opened our first primary care clinic in '95. The slide says we're now at 5, but it's actually going to be 7. We just opened our 6th inside a county-operated mental health clinic under Marv's domain, LA County. And the 7th will open up in a large mental health organization, the San Fernando Valley Community Mental Health Center, that is currently going through implementation right now. 2 of our primary care clinics also have specialty HIV/AIDS medical services embedded in them. 4 of them have Drug Medi-Cal certification connected with them. I've already mentioned that we have an acute psychiatric hospital. We do both inpatient detoxification and psychiatric stabilization in that particular facility. Over close to 30, I think now, sober living or transitional houses tied to our various facilities. Medication-assisted treatment is a big item for us. I have a couple slides where I'll talk a little bit about that later, because I think that we don't do enough around that across the field. And one of my favorites, we have a number of different needle exchange sites, and frankly, they work quite well at moving people from the street into care. I've already talked about the specialty HIV. I'll skip that slide for you here. There is a slide somewhere along the way. I'm not. Oh, okay. I'll just keep going. There is a slide that shows the integration, sort of a tree that shows all the various services. On the health information side, we use NetSmart Avatar. We have a primary care module tied to that. Everyone uses iPads in the clinics for services. We have one integrated treatment plan. Our mental health services, our substance use services, and our primary care services all use one treatment plan. We think that's a big plus. Order Connect for e-prescribing, Care Connect lab interfaces and HIE, My Health portals, and we use Zermed for our revenue cycle management efforts. The next set of slides are going to be more specific to the Drug Medi-Cal waiver situation, talking a little bit about screening and assessment. We all know that the ASAM is the criteria that the services are based on, but using that criteria is going to is already posing challenges to a lot of providers that are not accustomed to using it. And so there's going to be a lot of work around it that I don't think has been moving as fast as it should. The ASAM criteria may challenge us on the workforce front. It may require a different workforce on the front end doing that screening and assessment. It may require an increase in workforce to do that as well, that folks need to look at that and then on through their services in terms of any continued utilization review and coordination with counties about that that may impact staffing. Question about how providers address the whole person approach to healthcare. Challenging question. If you don't have it all in-house, where do you get those missing pieces? Who do you partner with? What does that partnering look like? Is it effective partnering, or is it just some of the same old in terms of refer and hope they make it? Big change on the residential side. All residential care will require prior authorization. Counties are responsible to provide that authorization within 24 hours. What happens if they don't? What happens to the individuals if they're delayed? We know that the window for folks when they're ready for help is extremely small and closes very fast. Even 24 hours can be too long. What happens if there's disagreements with those requests for authorization, and how do those disagreements get resolved timely? Will counties authorize the full 90 days under the waiver, or will they look to parcel it out like a health plan? You get 7 days, call us back. You get 14 days, call us back. If counties use that approach, which I urge them not to, But if they use that approach, and then we're talking about a huge increase in utilization review, the staffing associated with that, on the county side and on the provider side, where do the resources come from to do all that? So, continuum of care, lots talked about with the continuum of care. Some of the questions providers have about whether there are any incentives for agencies that don't have a full continuum to develop one. There are no incentives that I'm aware of for that. Obviously will be a stumbling block for many because they don't have the resources to do it otherwise. And here on medication-assisted treatment that we've talked a bit about today and talked about for a long time, it's nice to see what's moving forward with the options of additional medications under the waiver. We have a split system with medications that will be under the Drug Medi-Cal system and medications that are not, that are under the fee-for-service system. It would be nice if we could house them all together. I think it would be much more beneficial to the field. But the other thing with medication-assisted treatment and why I don't think it moves fast enough in terms of providers embracing it beyond the stigma and, oh, gee, it's got to be total abstinence kind of thing, are resources. If you think that the reimbursements when you submit a bill for a Vivitrol injection or for buprenorphine or whatever is covering all the costs associated with implementing that part of the continuum, you got another thing coming. It really is only covering the medication cost, maybe an injection fee, but there's so much more that has to go on that is not supported in the system. And if we don't start taking a hard look at that, we're never going to achieve the integration of medication-assisted treatment that we all know is badly needed. I've talked a bit about the QA and utilization review process. Here again, it's going to be a manpower issue, getting qualified people there, and where do the resources come from. Rates, I think in all of this that I know counties are struggling with, providers are worried about, where does the data come from to reach rates that are going to pay for what we need done. Looking at the data that we have in the system today is not a good way to go at it. We don't have enough data in the system for that. Looking at the cost of that substance use widget today in a cost report doesn't take into account all the things that need to go on that likely are not going on today because there's no resources to do them. And so we have to factor that in when we get around to establishing rates if we want to see this thing play out correctly. Medical necessity. Everything is driven by medical necessity. What do we do with the patients that meet medical necessity initially and then no longer meet that medical necessity criteria but still need some level of care? Where are the resources to continue that care? Recovery support's been talked about also today. The chronic conditions of substance use disorders and mental health, recovery support is such a huge piece of it. It isn't well defined, if it's defined anywhere under the waiver. And I don't know what work, I've not seen anybody lay out any draft definitions of what it should look like. And I haven't seen anybody lay out anything with regards to how it would get reimbursed in terms of rates. Workforce training. Beyond the training that needs to go on with ASAM, the fact that we're talking about medical necessity, there needs to be a lot of training with the workforce and understanding what that means. But I think most importantly for me is the cross-training that needs to go on when we talk about integrated care, whole person care. If, since we're sort of focused on substance use right now, if the workforce within the substance abuse field doesn't understand basic knowledge of chronic diseases that are being handled in the primary care arena, and they're working with patients that have those chronic conditions, which many of them do, we're going to fall short. We've got to get that workforce trained to understand those basics, to understand the basics in the mental health side, and vice versa with this. And I don't know of where the resources will come from to do that, but I think Sandra's going to probably try to find them because she wants CIBHS to start offering that training. Youth services. We're mostly an adult system of care, particularly in the substance use arena. Youth services are, of course, under the waiver. There's not a lot of talk about it that I've seen. Residential for youth is licensed by community care, and I'm curious how we're going to deal with the ASAM designation for youth residential facilities, because we can't link that to the license like we're doing on the adult side. And I assume that designation will be needed on the adolescent side as well. The SUD EPSDT benefit seems to stymie everybody in terms of what that is and how that gets used. Little information coming out anywhere on that as well. Information technology, integrated care relies on it heavily, at least in the substance use field, and I know, frankly, in most fields, but particularly in substance use, we're really weak on it. We're weak on IT, and there don't seem to be any infrastructure dollars to help aid in getting that IT up and moving. I mentioned earlier the CDCR sort of system of care redesign that it's going through, and how I think it's important that we're all at that table, particularly counties that are going to become responsible for so much of the direct care to that population, so that we can come up with a model that works for everybody. Building an integrated system to be successful with it requires us all to cooperate and work together. The additional services that are not covered by Drug Medi-Cal require that we keep the funding in the system that's there today. If we remove that funding, then we're likely not to do well with what we're trying to develop under the system of care that the waiver affords us. And I mention that because I've already seen it happen, and I've heard lots of dialogue about it happening even further. Other systems that fund substance use treatment, dollars that come in from DPSS and child welfare and general assistance or general relief, lots of talk about you don't need our dime anymore because you've got this benefit. And if they start pulling out those resources, then we're going to start to see a lot of lost benefit to the system. Thank you. Oh, I'm supposed to introduce the next guest here, Patricia Judd. Thank you.
I think he covered it all, but I'll try to add a few things. So I'm Pat Judd. I'm in the UCSD School of Medicine, Department of Psychiatry, and I'm here because within our department we have a few public programs. We have more private programs, private insurance programs, but we've had several public programs for many years, and I just want to describe the three that I think are most relevant to what we're talking about today. So one is, that I'm going to emphasize more, is a integrated substance abuse and mental health treatment program that was originally one of the California dual diagnosis demonstration projects. San Diego County was one of the 5 counties that was awarded this grant, and we ran for about 4 years. And then we were, the county, because we showed good outcomes, the county decided to fund us through joint mental health and, at the time, substance use services funds, so that it was, I think, among the first integrated funding streams in San Diego County of that sort. And then we've had a long-standing, since 1970, outpatient public mental health clinic with a contract through San Diego County. And our mission has been, because we're within the Department of Psychiatry, has been, one, to provide outstanding care, but also to train psychiatric residents, and also to train social work interns, psychology interns, marriage and family therapy interns, medical students, anthropology students. And so that has been more of a traditional outpatient service. And then the third program, which we ran for 5 years, just recently ended under our leadership, was called the Bridge to Recovery. And this was a novel program that was housed in our public psychiatric emergency room. And our goal there was to work with the patients who were seen in the emergency room, those who were in the hospital, as well as those who were just there for screening. And those who had substance abuse problems, we were to work with them and provide care coordination and linkage to community services. And that was more, I see that more as a population health kind of a program where it wasn't fee-for-service. We were there, we were funded to link as many people as we could to services, to hold them in a counseling relationship till they could get into the appropriate services, and to link them both to psychiatry, substance abuse, and primary care services, which our staff did. And so that was, again, but not fee-for-service. We could just go out and do our work. We didn't have to worry so much about what how we were billing. So I wanted to focus on, could I have that next slide there? Oh, I have to do it, okay. All righty. So one of the challenges that we've faced in terms of true integration of substance abuse and other mental disorders services is we have a contract with our county here in San Diego, which has been very forward in terms of integrated services, very progressive. But we're the county-wide service to provide that's truly integrated. Now, everybody in San Diego County is integrated to varying degrees, but we were funded specifically for full integration of services. So we see individuals who've had the most severe addiction histories and most severe mental health problems, and our staff are all cross-trained. It's a modified IOP kind of a program, and so we had mental health dollars, and then we had what they call general population dollars, and we had Prop 36 money for a while, and a little bit of DMC money. So just let me give you this as a case example. When we started out, when the county assumed funding, we were actually given a higher rate. We were actually given the mental health rate to provide the integrated services. I don't know how many years went by, but that then ended because of funding problems. So we then reverted back to the regular substance use dollars, which were a lot less than the mental health dollars. But we had to stick with the visit expectations of alcohol and drug because of the rate. So we had to, I think, do triple the number of visits for the substance use funding than we did for the mental health funding. So that created an enormous challenge. Then we had to then we got electronic health records. Wonderful. Great, they've been great. However, that was only done in the mental health side, but not on the substance use side. So we had one whole documentation system for substance use funders and a whole other one for mental health funders. So we were operating actually, and then the wonderful thing is when most of our patients got on Medi-Cal, Drug Medi-Cal, all the general pop dollars then went down, all the Drug Medi-Cal went up, and then they have incredibly stringent, we didn't have to really deal with that much before, the documentation requires on that made us have to have paper charts. So paper charts, we had another in-house documentation system, and then we had the electronic health system of mental health, and all these different rates. Well, staff have been going under with these different requirements, and it's an enormous challenge. It's no one's fault. It's just the way these systems have been structured. So that's a huge challenge, and I heard this morning some great ideas about how this might be solved, but that's something that has to be solved. So the payment rates are different, productivity expectations are different, documentation standards are different, and it's very hard to train a staff to get all this straight. How many Excel spreadsheets can you have to try to track it all? So the other thing I wanted to highlight is a challenge within all of our services, as there has been the movement towards health homes, primary care transfers, that while these are excellent ideas in principle, the challenge is getting people to the right level of care. Many of our patients have seen our place as their medical home or their health home, their behavioral health home, and disrupting them from that safe haven home is very traumatic to many of them. So as we have to figure out how we move people from specialty mental health, when they become moderate, when they become mild, how do we do this and preserve some of the attachments they've had and some of the sense of security, and to minimize all of this disruption? I think, so in terms of strategies. Obviously, a uniform payment structure would be wonderful for everybody. I heard this morning the idea of a variable rate structure. So, for example, our program with the integrated substance abuse services, if we had a rate that really, so we could provide the services that we do under a certain rate and not have these two uneven rate structures, and yet we provide the same services to each patient, of course, that would make a huge difference. The county worked very hard with us to try to, so we could convert to our electronic health record system for mental health services, but ran into enormous obstacles with the confidentiality concern the two. Right. So hours were spent on trying to move us over to that system, but they couldn't do the firewall. There was no way that they could work out that would still meet the law. So we had to revert back to this paper record system and another system. So unified documentation, working out that challenge, I think is terribly important for all of us. The other area is, of course, clear pathways for referrals. So I was thinking in our own system, and I'm sure some other people have this worked out better, but we have to have real clear pathways in our mind at intake to educate our patients. You're coming to us with your serious mental health for a while, and then we're going to help you, and these are what your options are with your managed care plan for your Medi-Cal, and how we link them and where they're going to go. And our system is, we have very rich in terms of especially mental health, in terms of access to ACT programs and clubhouses and a lot of things like this. The managed Medi-Cal programs are still working very much, as I understand it, on a fee-for-service outpatient basis. Also, they don't have that many providers who want to do the work. So there's a lot of work that has to be done in that regard also. So these are just a few of the challenges, and I'm certainly hoping, along with everybody else, that we can, that all of these things that are coming up will help us solve some of these problems, so we really can provide a seamless continuum of care for our people. Thanks a lot.
Are there questions for our panelists? We have about 5 more minutes for questions. Go ahead, Marv.
So it seems to me that in listening to all of you, there's a part that ought to be easy and a part that is much harder than you described. The part that ought to be easy is with the new substance abuse benefit. It seems like we have the opportunity to design it in such a way that the system interfaces happen between mental health and substance abuse, so that a lot of the issues described here can go away. And since we're inventing the system at this point in time, it seems like that opportunity is really a good one. The thing that's harder is that I think we need to look at even the mental health and the substance abuse benefits as a part of a larger ecology in our communities. And if we fix one part of the system but don't look at the whole community ecology, then things won't work. And I'm thinking particularly here of foster care system. I don't think there could be one thing that we could do more to improve the outcomes in the foster care system than having a robust substance abuse treatment network available, because I know in our county almost all the really terrible outcomes that happen in a context in which the caregivers have substance abuse issues. So I think the easy, I mean, it's not easy, but the relatively conceptually easy part is thinking this new drug benefit in a way that connects up organically with the mental health system. But thinking how that connects to the other large systems, I think, is more important but much harder. And I'd like your views on how we would address either the easy part or the hard part.
The hard part that I would want to address immediately, and I think that we need to do immediately, is regarding housing. and it's not the foster care system, but it's regarding housing. So on the new, we're very excited to have the new residential treatment benefit as part of the organized delivery system. But in some counties, it's going to be a shorter length of stay than was covered under, let's say, CDCR's payment system or a county's general fund system or whatever it was. And so if we cannot link up housing immediately upon discharge, if the length of stay in a residential treatment setting is 90 days for a person who was homeless when they came in, and if we can't immediately put them into a transitional housing setting, and we haven't developed the capacity for that, and then move them into either low-income subsidized housing or permanent supportive housing, then we're going to have a problem in the system. And if the new benefit also limits people to 2 episodes in a year, because the 90 days wasn't enough, and but there's no housing, then you're going to have people who are going to just simply drop out of the system.
That's a great example.
I would add, Marv, that I couldn't agree with you more. I mentioned earlier this morning the conceptualizing and the discussion of a lot of this is the easy part. The implementing of it is much more difficult, and getting all the players on the same page much more difficult. My comments about pulling resources out of the system really goes to that. It really is not the kind of partnering that we need to be successful in this.
And again, the siloed funding systems, the siloed charting systems, the siloed information technology systems, all those in concept, it should be kind of a no-brainer, but in reality, it's much harder to climb that mountain.
Great. Are there other comments or questions for the panelists?
So would you join me in thanking the panelists for sharing their information with us?